Thank you everybody for attending the McCance seminar series. This is Gene Bowman chiming in live from a vehicle, so I'm not going to share my video, but I'm excited to introduce Dr. Magdalena Opazo Breton, who's a visiting scientist from the Department of Epidemiology at the Harvard T.H. Chan School of Public Health. I've asked her to take maybe 30 seconds or a minute just to introduce herself to the group here, and she's going to be talking about making causal inferences and some of the methods that are utilized in her research. We're very excited to welcome her. Dr. Britt, welcome.
Thank you very much, Dr. Bowman, and thank you everyone for being here today. I'm honored to present this research to you. This is my fellowship project, so it's a work in progress. I won't be presenting any results, but just tell you about how my proposal was designed, and it will be great to hear any suggestions, or any suggestions are more than welcome by the end of the presentation. So this project uses causal inference methods in dementia prevention research, and it has been funded by a Nottingham Research Fellowship and the National Health Institute for Health and Healthcare Research in the UK through an NIHR Advanced Fellowship. I'm a senior research fellow in the School of Medicine at the University of Nottingham. And the short title of my project is, Can National Public Health Policies Reduce the Risk of Dementia? There. Well, first, I would like to tell you a little bit about myself. So I was born and grew up in Chile, and I did my undergraduate in sociology at Pontificia Universidad Católica de Chile. And then I did a master's degree in economics from Georgetown University that used to have a program in Chile back then. And then I moved to Spain and did a master's degree in economics again at Universidad Carlos III de Madrid. And then I did my PhD in economics at Universidad Autónoma de Madrid. After finishing my PhD, I moved to the UK and started as a research assistant in the Division of Epidemiology and Public Health at the University of Nottingham. There I progressed to research fellow, and in 2020, I was awarded a Medical Research Council fellowship and moved to the University of Sheffield for 3 years. Then I moved back to the University of Nottingham in 2023 as a senior research fellow. And after that, I've been awarded this Nottingham Research Fellowship and this NIHR Fellowship to deliver this 4-year research program on dementia prevention. And my previous research, so my background is mainly in economics, and my previous research has been touching topics such as smoking, alcohol, and obesity. Once I finished my PhD, which evaluated housing policy in Chile, I moved to the UK to study smoking behavior and evaluate tobacco control policies. And then when I was awarded my MRC fellowship, I expanded my methods from smoking to study alcohol behavior and alcohol policies and obesity, because I was in the alcohol group there and also collaborating with people from obesity. But my main focus has always been kind of policy evaluation using causal inference methods. Then I wanted to move to study dementia prevention. My grandma got diagnosed with dementia, so I thought I needed to do something about it. And I found that my previous research was connected to dementia, since it was touching several modifiable risk factors related to dementia, as those mentioned in the reports from the Lancet Commission on Dementia Prevention, Intervention, and Care. So the aim of my project is to estimate the effect of large-scale public health policies implemented in the UK on reducing the risk of dementia. And this project will use causal inference methods. It will have an emphasis on health inequalities, and will also have a strong public and patient involvement. This is called PPI in the UK. I haven't heard much of this in the US, but in the UK, it's something that is very important, especially in health and healthcare research. And if you're applying for funding, you need to have a strong strategy on how you will be connecting your research to the public and the patients, or the people that are going to be in the end affected by your research. So part of my fellowship will also consider this public and patient involvement. And the background of my research is the global concern about the growing number of people with dementia. And so in 2015, there were 45 million people diagnosed with dementia, and that number is expected to increase to 75 million in 2030. This is also related to the aging of the aging society, or the transition into an aging population. And this is also something that is happening in the UK, as we can see in figure number 1, where the number of people with dementia is increasing and also expected to continue to increase. This is not only challenging for the individuals affected by dementia, but also for their families, their carers, the national health system, the economy, and society in general. And especially in the UK, where there's a universal public health system that has to fund caring and taking care of all people with dementia. However, the latest literature, the paper from Walters 2020, suggested that in some high-income countries, the number of people with dementia is increasing, but the incidence of dementia is decreasing. And as we can see in figure number 2, studies for the US, for the UK, for the Netherlands, and for France show evidence that the incidence of dementia has been decreasing during the period 1988 to 2015. And this is kind of the background and the context in which my research is framed. So why I thought it was important to study the effect of policies. Actually, in the Walters paper from 2020, they say that the main challenging is finding the cost for this declining trends in dementia incidence. And there was not an explanation into why this is happening, but there was the idea that maybe changes in lifestyle or maybe other policies that have tackled other diseases could have contributed to reduce the risk of dementia in these countries. There's also the WHO, who has a strategic goal around gathering evidence of interventions that have been effective or cost-effective to reduce the risk of dementia. And there's a latest literature looking at population-level interventions that could have had an effect on reducing the risk of dementia. There's no estimated impact, but there's a systematic review of evidence that there's many policies that could have contributed to reduce the risk of dementia. So my project will study 4 policies that have been implemented in the UK and that are related to modifiable risk factors related to dementia. The project has been supported by Harvard, who has invited me to do a 6-month overseas visit here between January and June this year, and also by the WHO. I have selected these 4 policies. First, the annual flu immunization program, which started in 1960, the salt reduction campaign, which started in year 2003, and the Alcohol Licensing Act, which started in 2003 and was expanded in 2005. And finally, the smoking ban, which started in 2007. Alongside these 4 work packages, where each of them is a research project in itself, there's 3 strategic areas of my project. One is building collaborations for dementia prevention research. Another one is this PPI and stakeholder engagement area that I mentioned before. And also because it's a fellowship, they give you a lot of, there's a lot of funding intended to give me additional training and for my career development. So why using causal inference methods? Well, the idea is that we're going to use observational data, we will be using observational data and move from traditional observational studies looking into association to study causation. And to study causation, we move into using counterfactual reasoning and the potential outcomes framework. The question underlying this idea is that what would have happened in the absence of the policy? So we're trying to find a control group that will show us what would have happened if the policy hadn't been implemented, and we compare it to the situation where the policy has been implemented. And under additional assumptions, we can estimate an average treatment effect. I will be evaluating real-world policies where there's no randomization, and since there's no randomization, we'll be using observational or routinely collected data. There's lots of disadvantages of this, but there's also the advantage that it will allow me to look at much more extended follow-up periods. Causal inference methods also in economics, mainly they are specific research designs where you clearly need to define a treatment and control group and address the assumptions for each design But since you have a lot more data, it will also allow you to address heterogeneity effects of the intervention and also of the implementation of the policies. In the end, it's all about dealing with the absence of randomization, but causal inference methods will try to replicate a scenario as close as possible to an experiment, and will try to balance baseline imbalances, or also use confounding adjustment methods to kind of replicate these experimental conditions. And since I'm coming from economics mainly, the research designs I will be using, or I consider using for this research, or for each of these research, are related to the ones I have here. So some of them have also been started to be used in epidemiology, and some actually target trial emulation is from epidemiology, but most of them are from economics. So there's difference in difference, where you create a treatment and control group and compare treatment and control group before and after the policy was implemented, which under certain assumptions will allow you to estimate the average treatment effect. Then you have regression discontinuity designs, where you have a cutoff that determines a population below and above the cutoff, and you can compare them under certain assumptions and get the average treatment effect as well. Then you have synthetic control methods, where you have one unit treated and several control units that you can combine under certain assumptions to compare them to your treatment unit and estimate an average treatment effect. And then you have instrumental variables, where you have a variable that determines your exposure variable, but is not related to your outcome variable, or is related to your outcome variable only through your exposure variable, and will allow you to recover randomization under certain assumptions to estimate the average treatment effect. And finally, target trial emulation methods, which are from epidemiology, but are also a research design, in the sense that you are designing a research, you're using all aspects of the research to design a protocol as if it was a randomized control trial, with a very clear course of questions and specifying the same areas that you would specify in a randomized control trial to at the end estimate an average treatment effect. So those will be the research designs that I intend to use in my proposal, in my research project. And now the data sources. So I will be using only secondary data sources, some longitudinal, some cross-sectional, all data sources that are available for research in the UK. In terms of the longitudinal data sources, I will use the English Longitudinal Study of Aging, which started in 1998 and is still ongoing. Then the Clinical Practice Research Data Link, CPRD, which is electronic health records from the health system in the UK, from 6 million people follow over time, and it started in 1998 and it's of course ongoing. The UK Biobank, which started in 2006 and is still ongoing. And in terms of cross-sectional data, there's the Health Survey for England, which started in 1998 and is still ongoing, and the National Diet and Nutrition Survey, which was between 2001 and 2014 to cover the period of the salt reduction campaign. As I mentioned before, my project will have an emphasis on health inequalities that are relevant to dementia research in the UK. So I will try to explore heterogeneous effect, looking at ethnicity, pre-existing medical conditions, geographical area, socioeconomic status, and sex. I will move now into telling you about how I've been using these causal inference methods for this research in dementia prevention. I will describe each work package, so each policy. Some policies have been more developed than others, so I will start with the more developed ones and end up with the ones that have been less developed so far, because I have very recently started with this project. So first, the annual flu immunization program. As I mentioned before, it started in year 1960, vaccinating people over the age of 75. But in year 2000, there was a change in the policy, and they started vaccinating people over the age of 65. There's evidence that immunization in general can reduce inflammation, and in that way can reduce the risk of dementia. It's also said that it can be a boost to the immune system, a yearly boost to the immune system, and in that sense, it could reduce the risk of dementia. However, there's still scarce evidence about immunization and dementia, though the evidence is growing, especially for the zoster vaccine. I show some data later about this. But I want to contribute to this literature on immunization and dementia, studying the annual flu immunization program. For this study, I will use the target trial emulation methods and a natural experiment, which is that the policy change after year 2000. The outcome will be diagnosis of dementia, and I will compare vaccinated to unvaccinated people, but in a target trial emulation context, which I will explain a bit further. And the data will be electronic health records, which is CPRD data in the UK. So to specify the target trial, I have written a protocol and I'm applying to the data. So, and the eligibility criteria will be patients registered in the practices that are available through CPRD data that are aged 65 to 74 in year 2000, because we know that people only started vaccination in year 2000 and were not allowed to have vaccination before year 2000 unless they were in a risk group, but then they would not be in my eligibility criteria. I also will exclude people with history of dementia in the last 2 years. And the treatment strategy will include people initiating vaccination as soon as age eligible. So in year 2000, someone who was over 65 was age eligible, but probably in year 2001, only someone who just turned 65 and those who delayed vaccination will be eligible for my trials, because I will be using sequential trials for this study. There will be no randomization, but target trial emulation use methods. You assign your population to the different treatment strategies, and then you adjust for baseline covariates using inverse probability weighting, G-estimation, stratification methods, or matching. The follow-up will start immediately after the influenza immunization campaign ends. The influenza immunization campaign starts in September each year and ends at the end of December. So we will assess vaccination status after the 31st of December. Then we will start follow-up, and it will continue until dementia diagnosis, death, or administrative censoring. And we want to do follow-up of 5, 10, 15, or 20 years if possible. I know some studies have used 10-year follow-up for dementia, and they were around 2011, 2012. So I'm expecting that we might be able to follow up for 15 for sure, but maybe for 20 years. The outcome will be dementia diagnosis based on medical records, medication, and death registry. The causal contrast will be intention to treat or per protocol analysis. And in the analysis, we will be estimating risk differences, risk ratios, and incident rate ratios. And I will try to do subgroup analysis by sex, different age groups at baseline, because age is very important for dementia research. And I will also use a number of vaccinations throughout the follow-up as a subgroup analysis. So it will be a sequential trial and a natural experiment. The natural experiment is that we have the fact that people over 65 were non-vaccinated before year 2000, so they will start vaccination in the influenza campaign of year 2000, 2001. Everyone between 65 and 74 will not have had vaccination before. We will determine if they are eligible and non-eligible, and they will enter a trial that will be follow-up for 5, 10, 15 to 20 years. Some of those non-vaccinated will be people who have decided to delay vaccination, so they will maybe start in the second trial as a treatment group, but will have contributed to the analysis as a control group in the first trial. And that way, for all people age, and we will follow this until the year, throughout time, and repeat until their 75th birthday. The advantage of the natural experiment in this target trial emulation framework is that it allows us to align time zero with treatment assignment and start the follow-up, which is the hardest thing to do with observational data, and that it can lead to immortal time bias. So I believe that using these two methods will allow us to estimate a more robustly effect of the influenza immunization on the risk of dementia. And as I mentioned before, I would like this to contribute to other literature on immunization and dementia, which has also used causal inference methods, in particular from economics. So these two papers, one for Wales, one for Australia, have used regression discontinuity design and the natural experiment of the date of eligibility for vaccination to zoster vaccine to estimate the effect of zoster vaccine on dementia diagnosis, and they have provided strong evidence. So hopefully, will be able to contribute to this literature when I get the results. Then there's the Alcohol Licensing Act. This was an alcohol policy implemented in the UK, which gave power to local authorities, which are small area geographical authorities in the UK, to control availability of alcohol and the alcohol environment. And there's evidence that this policy reduced alcohol-related hospital admissions in those local authorities where there was a higher enforcement of the policy. So there was not an equal enforcement of the policy across local authorities, and this allowed to find an effect on alcohol-related hospital admissions, and I'm expecting to use that differential enforcement to study the effect on dementia. I will use a difference in difference design and use this differential intensity by local authority as a treatment strategy. And the outcome will be all-cause dementia and cognitive function. Because it's a difference in difference, I will need to create a treatment and control group and study, and under certain assumptions, compare them before and after 2003 to see if there's an effect on dementia. The data for this study will be the English longitudinal study of aging, because it has information at a local authority level. And I think it's the only one that has information at a local authority level so far. The sources of identification for the difference in difference model are these. So as you can see in the figure in blue, there's a differential, a different distribution of alcohol-related hospital admissions across the UK. And the figure at the right in gray and white, it shows that there's differential enforcement of the policy. So the dark areas were areas where the policy was enforced more, and the white areas are areas where there was no enforcement of the policy. So this will feed up into the difference in difference model. In the end, it will use the intensity, this variation in intensity of the policies across local authorities to create a binary treatment variable. You could compare non-enforcement to some enforcement, or you could also create a categorical variable, non-enforcement and different levels of enforcement to estimate the treatment effect. The question I want to answer with this study is the risk of being diagnosed with dementia different in policy intensive areas compared to non-enforcement policy areas? And that would be the alcohol policy part of my fellowship. Now the smoking ban, which started in 2007. There's no evidence that the smoking ban in the UK reduced smoking, but there's evidence that it reduced exposure to secondhand smoke, and secondhand smoke is pollution, and pollution is linked to dementia. So that's the link I've made to study the smoking ban. And cotinine, it's a biomarker for secondhand smoke exposure, and it's available through different surveys in the UK. So I have designed a difference in difference model again. The policy will be after 2007, when there was a prohibition to smoke in public places and in the workplace. So you can compare before and after 2007. The outcome is cognitive function. And again, I will define treatment and control group, which under certain assumptions, I will be able to compare before and after the policy to estimate average treatment effects. The data in this case, there's the English longitudinal study of aging, the health survey for England, which has cotinine levels, and the UK Biobank also measures exposure to pollution. What evidence do I have for this model, there's evidence that pollution, and in particular PM2.5, which is also the pollutant associated with secondhand smoke exposure, has a high is related to a high risk of dementia, as mentioned in this study. And in relation to secondhand smoke exposure and the policy in the UK, there's this evidence that the proportion of people with undetectable cotinine levels increased up to 2007 when the smoke-free legislation was imposed in the UK or in England. And also the geometric mean for cotinine decreased after the policy was implemented in July 2007. So to identify an effect in this case, I will use the differential in exposure during midlife to secondhand smoke. I will study those birth cohorts that were exposed to higher levels of secondhand smoke because there was no policy in place, and compare them to birth cohorts that were exposed to lower levels of secondhand smoke because they were exposed to the policy, and study if their cognitive trajectories differed after the age of 60. In the end, the question I want to answer is, do cognitive trajectories by age differ among people with different exposure to secondhand smoke in midlife? And finally, the salt reduction campaign. This one started in year 2003. It was a voluntary scheme between the government, the food industry, and the third sector. It was not like an obligation, it was not a legislation, it was a voluntary scheme, but there's evidence that it contributed to reduce salt intake and it lowered blood pressure in the population, and it was also associated with reduced cardiovascular risk. So I now want to look if the salt reduction campaign was also associated to reducing the risk of dementia. The research design will be similar to the one I just mentioned for the smoking ban. The policy, it's a voluntary reduction. It's related to voluntary reduction targets, but there's varying intensity in the policy. The policy was more intense between the period 2003 and 2010, and it continued afterwards, but the intensity of the policy and the enforcement was less strong than at the beginning. So I will use that to identify the policy. The outcome will be all-cause dementia and cognitive function. And again, I will need to create a treatment and control group, which under certain assumptions will allow me to estimate an effect comparing before and after the implementation of the salt reduction campaign. In terms of the data, there's the English Longitudinal Study of Aging, the National Diet and Nutrition Survey, the Health Survey for England, and the UK Biobank, that some provide measures of urine, salt intake in urine samples, the other ones, cognitive trajectory and dementia. In terms of the sources of identification for this difference and difference model, in black and white here we have the salt intake that was associated to the reduction in salt from the salt reduction campaign, and you can see that it went down from 2003 when it started until 2014, and then it went up in 2018 when it changed after 2011, actually, because you can see in the figure, in the next figure, that the policy intense period was between 2003 and 2010. In this study, they used a time series interrupted model to compare trends in salt intake through urine samples in males and females. And as you can see, there was a clear decrease until 2010, which changed after 2010 and changed so there was a change in the trajectory, a jump after the policy became less intense. Thinking that there's birth cohorts who were exposed to higher levels of salt intake during their midlife, and birth cohorts who were exposed to lower levels of salt intake during midlife. And I will compare these two, combining information of salt intake by birth cohort from the National Diet and Nutrition Survey and the English Longitudinal Study of Aging to have cognitive decline. In the end, the question I want to answer with this study is, do cognitive trajectories by age differ among people with different exposure to salt intake in midlife? So I've showed you now the 4 projects I will be developing in the next 4 years. I wish I had results, but of course, I'm just starting to define my models and finding sources of identification for each of the models. But even though I'm still in very early stages and would really appreciate any suggestions that you have, I've already been thinking on how this will move forward in the future. And so the next steps in my research will be to study other policies such as education and retirement, which are maybe closer to economics than to health. I've also been talking to Dr. Yuan Ma here at Harvard to transfer this project to US policies. And I'm also working with Professor Martin Orrell at the University of Nottingham to study dementia prevention in primary care and community settings. So, well, this is my presentation. Thank you very much. Thank you very much for inviting me to present today. I would like to acknowledge the mentors of my fellowship, Professor Martin Orrell, Professor Carol Brine, Professor Laura Gray, Professor Ian Buchan, and Dr. Yuan Ma from Harvard. Thank you very much.
Thank you very much, Dr. Breton, for that wonderful presentation. Really looking forward to seeing some of the results from this massive effort, and kind of diverse as well. I had a question about the salt intake.
Mm-hmm.
Do we think that it is in fact because of the biomarkers that you've also studied that indeed it is the salt that is the key factor for the reduced chronic disease in terms of cardiovascular events and things of that sort? Or is it possible that it's a mixture of effects maybe that have high salt intake, such as ultra processed foods, or potentially frozen foods, things like that. I was just wondering if your data can indicate things along those lines as well.
Thank you very much for your question. It's very interesting. Great question. I agree that, the effect, first of all, might not be direct. So I might need to do a mediation analysis with other things, such as cardiovascular disease, maybe, because it could be a decrease in stroke and that decrease the incidence of dementia. So yeah, I agree that there needs to be a careful thought on how the mechanisms through which salt intake is related to dementia risk later on in life. In terms of ultra processed foods, that's a super interesting comment, and yeah, something I will need to consider how to address. I considering that the policy was in 2003, probably the market of ultra processed food has changed massively after year 2010. So
right.
Yeah, I think there will be something to incorporate into the analysis related to the increase in ultra processed foods in the market, something like that.
Thank you. I noticed there's a question also from Dimitri. Sorry, it looks as if his microphone's not working, but had a question in regard to the diagnosis. It looks like it's a question related to case ascertainment in your studies. How is the diagnosis of dementia met, and how do you detect those changes in those criteria over time?
Yeah, thank you very much for that question. Yeah, of course, I'm very new to dementia research, probably newer than all of you here. I thought I'm bringing my expertise from policy evaluation to dementia, and that's why I have a very big group of an advisory board,
right.
providing me expertise on this. but I agree that even the definition of the outcome of dementia is already questionable, and I've had this
Yeah.
question before. So I
Right.
guess it's uh, what I believe is an option is that's why I've suggested to use different data sources to kind of find robustness in different data sources and
Right. Right.
but
I,
yeah,
I
so
mean,
there's options, I guess, but it's never going to be perfect. And I think
yeah, yeah,
dementia
no,
as an outcome
well,
is already complicated enough.
it is complicated, but you have real world data. And, at least in the US cohorts, this is typically done using ICD-9 codes or diagnosis codes that are
Hmm.
then reported to an electronic medical record. And so that can be, people moving from normal health to cognitive impairment or a cognitive disorder or a dementia of some form or fashion with a certain code attached to it.
Yeah,
Um,
yeah,
but then
that's
there's
exactly
also,
it.
yeah, I mean, but there's also options um, for biomarker definitions,
Hmm. Yeah.
biological markers of
Hmm.
potentially things that change prior to the diagnosis that could be a what you would call a case, but maybe a case of somebody at high risk rather than the actual disease itself. Anyhow, it's an interesting question that Dimitri brings up. I'm sorry, his microphone did.
Yeah.
Are there
So
any
I'm so
others?
sorry.
Yeah,
I'm sorry the
sorry, go ahead.
microphone is not working because I wish I could have heard of any suggestions because people probably here are maybe working with the UK Biobank and know certain biomarkers that could be used to kind of ascertain dementia in a different way and not only with medical records or medication as I'm doing so far.
Well, I'm sure that Dimitri and myself and Professor Tanzi and certainly a couple other people could help you with that. No problem. A lot of the blood-based biomarkers are really just coming to
Yeah.
fruition now. Some are reflecting more of the plaque, and others more of the tangle pathology, and then some degeneration of you know skeleton aspects of the cell that break and shed off, and then we can collect those in the blood. And it turns out that some of these work quite well. p-tau 217 actually does a really good job in the bloodstream of detecting amyloidosis in the brain. Anyhow, any other questions here? Elizabeth, do you see anything else? I'm looking on my phone here.
No, just Dr. Prokopenko followed up with your comment, Gene, that in large biobanks, usually ICD-10 codes are used if there's no clinical diagnosis. Just confirming
Yeah,
that response.
right.
Mm.
Okay, good,
Yeah.
good. So that's still utilized there. So that's great.
Mm.
Um, I'm certain that there's some diagnosis codes that you could use in a large data set like that, just pre-specify. Um, and also the vaccination records. Um, have you thought about potential modifiers of that relationship and how you might model that as well? You were talking about mediation analysis
Mm.
for salt intake, but what's your thinking in terms of how to model these big data sets in terms of looking at vaccination
Yeah.
impact on health?
In terms of vaccination, something that people have suggested is that I need to be careful with health-seeking behavior. So there's
Yeah,
literature in the UK using the CPRD data on how to address health-seeking behavior because it could be a major factor contributing to people going for vaccination just for health-seeking behavior, and then you will get less dementia because of people who are healthier anyways. So yeah, I'm thinking
right,
that I need to
right.
explore mechanisms for health-seeking behavior
Okay.
while studying the influenza vaccination. Yeah, that's one for sure. But maybe you or anyone has any others. I'm happy to listen to any other suggestions.
Well, I think it's thinking about the response to the vaccination, what the vaccine is, and the individual by which it's deployed.
Hmm.
Um, so I think that's a longer discussion, but I think you easily I guess what's nice about that data set is that it's very clear if somebody's getting the intervention, right? I mean, if you're vaccinated, there's a clear record of it.
Yeah.
As opposed to, you know, consuming salt, it's a reflection of somebody's
Yeah.
recall, right? So you have a really nice exposure there, but you're talking about, I'm trying to think of the type of bias. I guess it's a form of information bias, a misclassification bias that you're talking about that could be a nuisance variable that would be health-seeking behavior of those individuals, and how to remove that as a nuisance variable and get a true assessment of the association. Just thinking out loud, it's really pretty interesting because you're working in different areas, 3 or 4 areas that are quite large and challenging, complex.
Yeah, the good thing about the UK is that this data set, like CPRD data, and because in the UK, most people, not everyone, but of course, most people go through the universal health system. So you have more probabilities of having everyone, and not like other countries that have private and public health. So I think, and because the immunization, you know, you have records of people having immunization, flu immunization, like not only with the GP, but also in a pharmacy or even in community settings. All those are registered there. So we'll see. You know, data is data, and there's of course always limitations to it. But data in the UK seems very comprehensive to study. This, we'll see what happens.
Yeah. Well, thank you for the comments. Well, I could go on and on, Dr. Breton. If there are no more questions, though, I think we'll probably let everybody have their last 10 minutes of their hour here. Yeah, I just want to say thank you again for coming, and we look forward to the future and some of the publications here. And if you want to talk more about the design and some thoughts from the neuroscience standpoint, this crowd is very strong in neurology and neuroscience as well. So maybe there'll be some spark for some collaboration in the future.
Sounds wonderful. Thank you very much for having me today. And you have my email there. If anything, happy to discuss this or anything else with anyone who's interested.
That sounds great. I just wanted to mention also that this will be recorded and posted on our YouTube page so that we can get further details of what was presented as a review. Thanks a lot.
Okay. Thank you. Thank you, everyone. Take care. Bye-bye.
Thank you.